Hello and welcome to How Health Systems Work. I'm Jim Burke, here with my co-host Steve Pratt. Steve?
Hello everyone, thanks for joining us today. Today we have a guest who's been a friend and a client for many years, several decades, Bain Farris. Bain's had a remarkable career as an executive. Bain's going to talk to us about how healthcare works and kind of how healthcare is changing. So with that, Bain, if you don't mind, introduce yourself and tell us a little about your career in healthcare.
Thanks, Steve. My career in healthcare started with my father. He was a physician, and so following him around, you got to see what he was doing. And so when someone said, "What are you going to major in college?" I said, I think I want to be a physician. Realized pretty quickly that that was not the track I wanted to go down. I loved systems. I loved how things work. I loved to figure things out. But biology, chemistry, and physics were not my strengths. And so ended up switching to sociology because I liked to see how systems worked. Got a master's in health administration from IU at the time, the School of Medicine, and then went to work shortly thereafter for St. Vincent Hospital and was there for 23 years. For 13 of those years, I was either the COO or the CEO. Left there to go work at Anthem, which was the old name for Blue Cross Blue Shield of Indiana. And was there for 4 years, and then got involved with a small healthcare consulting company that was started by my CFO. Did a lot of interim CEO work there, and then went back inside in California and then Denver, and most recently returned back to Indiana, retired in 2017. But was over a small system in California, was over a system that partnered with Kaiser in Denver. And so I've had a sort of breadth of lots of different experiences in my time.
So Bain, as I listen to that, I can't help but think about all the times we've said we're going to move from volume to value in during your career. And so you've heard it so many times. I've talked to, particularly CFOs seem to be good about this, saying, "I'll believe it when I see it. It isn't going to happen before I retire." I guess it didn't quite happen before you retired either. What do you think? Are we almost there yet, Bain?
Well, I don't see much evidence yet, Jim. The problem with the whole idea is everyone's just trying to save money. I get that. But if you don't make substantial changes in the structure of the system, you're trying to put a big engine on a vehicle that can't carry the engine. And so that's part of the problem. Until I see there's a true interest in reorganizing the structure of healthcare, all this other is you're simply just trying to put higher fuel in it and change the tires. And
so, Bain, do you see that coming from payment models, or do you see it coming from the way physicians organize themselves, or the way hospital systems organize themselves? How do we drive that change?
Well, when you look at who pays today, again, I don't know I've been retired for 8 years now, so these are not the most current numbers, but even when I was a CEO, over 50% of my business was Medicare and Medicaid. And since I was in Denver, I was the Kaiser Hospital in Denver. So 75% of my business, of the commercial business, came through Kaiser. So where it comes from is who's the major payer. I had a partner who cared about cost, who had 1,200 physicians and a health plan and was 70% of my business. So it was easy for me to want to be careful about cost too, but they also cared about care delivery. They also cared about the structure. And the problem I have with the federal government, especially today, and the state government, especially today, is they care about cost, but they don't want to do anything to tinker with the structure, which is how you actually save the cost.
One thing they have done, Bain, that presents the possibility of changing the structure is they've changed the law so that we can now partner with doctors. We can safely pay them for quality care coordination and cost reductions. And those are tools we didn't have 5 years ago. So my belief is that there's a real commitment to try to drive down the cost of healthcare, and they're giving us some new tools to work with. I've always seen you as an extraordinary champion of physicians as partners. If you can think of examples of when you've partnered with docs, I'd love to hear about those.
So again, as I gave my introduction, I start with being a son of a doctor, right? So I happen to like doctors. In fact, my father was one of the heroes of my life. And I was raised around doctors. I saw them at swimming pools, and I saw them having drinks and having barbecue. They were just other people to me. They weren't They were my dad's friends. They were his colleagues. When I was an interim CEO for the 9 hospitals and systems that I was the interim CEO for, the first week, I set up a meeting with all the past presidents of the medical staff of that facility. And I took them to breakfast. And I talked to them first. And I said to them, I don't know how to make a decision what's good for the hospital without talking to you. And my goal is I want to find the smartest physicians who have integrity, and I want to listen to them. And everyone around the room nods their head and thinks that's great, to which I then say, I didn't say I was listening to you. I'm going to listen to the smartest physicians who have integrity and have the interest of the hospital at heart. And they go, okay. But that opened a door. They laughed, and that opened the door to get people to come in and tell me what they thought. I don't know how to make decisions on how to run a hospital without engaging physicians as partners. I wrote an article when I was assistant administrator about partnership in ambulatory care 1,000 years ago. But and again, it's just, that's not any different today. The problem is physicians don't have decision rights. They're not at the table at local hospitals because a lot of that control has been taken to the regions or to the health system. So the guy or gal who's running the local hospital doesn't have a quarter of the authority I had at every hospital I was at.
Do you see systems today, some of that focus on partnering and some that focus on, I'll call it, controlling physicians?
Absolutely. And some of it has to do with just how they were formed. I mean, if you look at Mayo's, and Mayo's was formed in a merger with a major physician group and a local Catholic hospital, right? And the guts of that organization is about physicians. Kaiser has a major physician group and a major health plan, and they tussle once in a while, but it's the physicians have a real seat at the table. A lot of other health systems have not gotten that, and they unfortunately think that by making the CEO an MD, that satisfies it. Well, there's a lot of university hospitals across this country that have difficulty talking to physicians just because, and they're all run by physicians. So one of the issues, Steve, an example, we built a new hospital in Denver. And part of what I asked every medical staff department to do was to participate in not only process improvement exercises, but all the space planning for the various areas. And they complained. I personally called them and told them, you got to come to this. Okay. So when the hospital was opened, a CV surgeon, I talked to him the day after he did his first case. I said, how'd it go? How was it? He said, it was perfect. He said, I changed the 2 screens in the room and we did the case and it was perfect. And then he smiled. He said, now I know why you had me go to all those meetings. Again, that's the payoff. And it's not just in construction. I don't know how you do anything of substance to a hospital that talks about change or improvement without having physicians not only at the table, but their input really being not always followed completely, because you'll have conflicts there too. But you have to have them at the table to advise those of us who have essentially MBAs.
You know, we sometimes struggle. We get started on a project in a hospital or health system. We say, look, we're lagging in some service line, right? We're just not meeting the needs of the community, the wait times, the whatever it is. And we start to do planning and we start to kind of figure out how we might address that. And if you bring the doctors in early, it's sometimes tough to just do some basic things while they're there. And if you bring them in late, you get a lot of pushback that, you know, you've made decisions and you don't really care what I think. Tell us how you manage this process. It's not easy.
Well, and again, at the hospital in Denver, when I was the CEO of St. Joe's, I approached the first 4 months as if I was the interim. Again, the first week I called in the past presidents of the medical staff and I did all the stuff to connect because I had to as an interim because I'm only going to be there for 6 months. But I did the same thing the first 4 months as if I was an interim, and it paid off that by the end of the 60 days, I knew all the department heads. I knew everybody who was in clout. I knew the leadership of Kaiser. And then I said, now we're going to build a new hospital and I need you to be at the table. I use those words. And I'll be at the table. No. I'm going to ask you for time that I know you don't have. Oh, okay, I'll come. And if you don't, I'm going to call you. Okay. And I did. And at the end of the day, I got the response of, you know, I understand now why you made me go to all those meetings. If you don't, Jim, if you don't do it If you do it too late, then it's, you don't care what I think. You've already decided I'm not going to pay any time or attention to it. If you do it front end, I haven't got time for this. Yeah, you do, because this is going to build your new OR. This is your new special care nursery. This is your new ER. And again, the folks who are vested, get it and will jump on board. It's a lot harder when you're trying to do that with private practicing docs who are already overworked and undervalued.
So one of the ventures that you pursued that I was part of was with cardiology. And I look back now at what a remarkable cardiology program you built. Tell us a little about that journey, because cardiology, orthopedics, and a few other specialties are the focus of often the initial efforts to work with doctors. Tell us a little about your experience working with cardiology to build a robust program.
So the credit for cardiology, Steve, comes from Sister Carlos, who came in to talk to Bob Cannon, who was my boss when I was the vice president. He was COO, and said, we're going to start a new heart program. And he said, a heart program? He said, heart surgery program. Oh, I just had a meeting with Dr. Shoemaker. He's retiring from the medical center. They're making him retire. He can't be a department chair anymore, and he doesn't want to quit. So he's going to come here and start a new heart program. So that was the start of it. He recruited John Ish. We had Ed Steinmetz and Bill Nasser, each who had 3 partners at the time, separate groups. They grew. And that's when I was part of it. Trying to balance the 2 competing groups, which now together are the care group. So they're all one group today, but that happened after I left because I was okay having them separate when I was there. Cause it was, kept everybody honest. But as it turned out, you had to balance. And at the end of the day, I won't mention his name. There was a cardiology meeting yesterday, that I got invited to, and there were like 300 people there talking about new advances in cardiology at St. Vincent's. There were 2 physicians who walked up to me and said hello, who were cardiologists, who literally never had a good word to say for me the whole time I was at St. Vincent's. So, as I said, the longer I'm gone, the better I was. Even though I told them stuff they didn't want to hear, over time, you realize that I'm not doing it because I'm trying to be a jerk. I'm doing it because it's good for everything. And if it's good for everything, we'll all be better and it'll all grow. And it did. So the size of the care group, the size of the heart surgery group, the size of the hand surgery group, the size of now the neurosurgery group they're adding a building for, is a sign of early partnerships that at least I had the authority and I had the clout. If I said, we're going to do this, I could get it done. And they knew that. They knew the sister before. I was the first non-sister CEO. And so before that, they always knew the sister could do it because it's her hospital. They weren't sure about me. And after a while, they realized, okay, I could get it done too. But at the moment, you don't give and empower the local leadership to do what they can do to build the partnership, then you won't have a stronger partnership.
I'm curious, Bain, because that kind of strikes a note, having worked inside health systems. There's always that tension between local leadership and a system.
Well, and Jim, part of the story that Steve knows that I didn't put in the introduction is when I was made COO at St. Vincent's, which was the largest hospital the Daughters of Charity had in the country at the time, I was 32. When I was made CEO, I was 36. So, to keep me on a short leash is probably okay. They always put their best sister here. The strongest daughter of charity they had, they put at St. Vincent's, always. And the problem was we got so big and the best sister went someplace else just before to put out a fire someplace. And they looked around and nobody had the experience that I had because I'd been here 15 years already. So I just got lucky, but yeah, there's always I had a shorter leash early on that over 9 years, it got longer, right? And that was fine because I proved I could do it. But I'm not talking about levels of authority and approval levels. I had the ability, if we'd said we're going to do something, to say it was going to get done. And I had to get Evansville to approve it. But St. Louis, I didn't really have to because St. Louis wasn't there then. It was a regional body, was the final authority, and that board. So it's a both and to the degree that health systems, and I'm not just talking about the daughters, I'm talking about literally all of them, the non-for-profits, get more interested in non-healthcare related ventures, it confuses the medical staff and the associates as to how come we're putting money in that when in fact we don't have enough money to do this or that at the local hospital.
Given your experience working with docs, if you were talking to a young executive and wanted to give them advice on 3 or 4 things that are the most challenging to overcome, the biggest barriers to creating partnerships, what do you think they'd be?
I think the first one, and this comes from my interim, doing 9 interim CEO jobs, and it's true if you're a new CEO too, to find out as quickly as possible who has integrity, who's high quality, who can you trust? Because again, these are people in my world I'm going to count on for information on which I'm going to make decisions. So, and I think every CEO should do the same thing. So who are the people that have integrity, that you can trust? That's one. 2, in every case, what are the 3 things that if you don't tend to can sink the boat? Because in the old Maslow's hierarchy of needs, if I don't do something to keep the lights on and keep the air conditioning on in the summer, my ICU doesn't work. So you got to do basic stuff. And then the second is to understand your leadership team and to make sure that you've got input from all sides there, including nursing. But you also have physicians in non-traditional roles. You've always got a physician medical director. I get that. But I had physicians in other roles sometimes that were critically involved with strategic planning, I put them on the board, I put them on finance committees, I put them on places to both educate those committees and also for them to learn the details about how the hospital really runs. So at the end of the day, you're it's overused, Steve, but the CEO is really the conductor of the orchestra. He or she doesn't play an instrument anymore, but they've got to make sure that the bassoons come in when they're supposed to and that the violins are all together. And you can't do that without a strong cadre of physicians that you can go to.
We've all seen the CEOs that are, on the billboards and out in public and really public facing, engaging with the community, sometimes to a point that, you get the eye roll over all of that. And then you get CEOs who are, on the floor all day, often coming out of a care delivery background. And of course you have to have both, but what's the mix? How do you find the right mix we've got listeners that are either early career CEOs or aspiring to be CEOs. And how do you figure out what the right balance is? Because you can't run an organization if you don't know what's going on. And an organization can't survive if it doesn't have the trust and support of the community. So you need both, but they can sure be taken to an extreme.
Remember, coming in as the first non-daughter of charity CEO at St. Vincent's, I was never going to know as much as they did. Because not only did they walk around the halls at night and in the middle of the night, but at dinner, they had 7 or 8 other sisters who were telling them what else was going on. So, I'm already behind, right? If you're not walking around the halls and if you're not known when you're walking around the halls by associates, by nurses, by doctors, then you're not out enough, and you're never going to be out enough. You're once you get in the walls, you can spend all day in your office and never leave, and you've got to literally force yourself to get out. Sister Teresa had every so often on her calendar, she'd put something on her calendar that said, "I'm going to go to the state fair." What? And her secretary, "What are you doing?" "I'm blocking the day off for the state fair." No, she never went to the state fair. She just blocked the day off. Because if she didn't, her secretary would fill it up. She said, "You got to block time, even from your secretary, because otherwise they'll fill it up and you won't be able to get out and see people." And so again, Sister Carlos, when she came back to stay after she'd retired, she came to visit me and she said, "What do you want me to do?" I said, "I want you to walk around the halls and tell me what you see. We'll meet once a week." And this was the first daughter I ever met, this daughter of charity. And she said, do you go to orientation? Do you physically go to orientation? I said, "No, you should do that. That's the only time most associates are ever going to see you." And again, every opportunity you get to go to talk to folks inside the hospital is fine. You still got to do Kiwanis and Chamber of Commerce and all that stuff. But you can't, until the place is running, you have to act like an interim and fix the problems before you can go out and do the other stuff.
So Bain, I'm curious, you were coming to the end of your career as we were really experiencing the shift. And I don't know at what point your hospitals made the shift from doing more volume, more revenue from outpatient than they did inpatient. And we were so stuck in our ways that we even came up with metrics. I think we still use them to this day of, inpatient equivalents, right? We'd take our outpatient numbers and turn them into, if this revenue had been from an inpatient stay, how many days would it have been, right? What would our census have been and all that nonsense? So as you see that progression and you hear folks talk about the hospital no longer being the center of the universe for healthcare and care being provided at home in different ways, even simple ways, right? At home dialysis, home hospital at the other end of the spectrum. That's not so simple, but lots of things are being done, sometimes because of economics, sometimes just because it's better to do it at an ASC, or to do it somewhere off campus. What are your thoughts about that shift? And you've had a time now you're still connected to healthcare, obviously, and you still know what's going on. What are your thoughts about that progression, and what does it mean for us as an industry?
Well, Jim, you're exactly right. And part of the issue was we got upset when a doctor put a diagnostic piece of equipment in his office. How dare you put a EKG in your office, cardiology? Really? I mean, and so those days are gone, thank God. But the other part of my background I didn't tell you, my first real job out of the sort of more menial jobs I had to start with, I didn't do the whole list, Steve, because I would take the whole podcast. But I was an assistant to a doctor who was vice president over ambulatory care. He was a pediatrician, and I was the assistant. And then when he left, I replaced him. My first job as an administrator, vice president even, was over ambulatory care, because nobody wanted it. And St. V's at downtown had 90-some% occupancy. So we had no inpatient beds. We had 380 or something beds. And so ambulatory care was the only way we could take care of patients. So I got all kinds of leeway. And then I built a brand new ambulatory care system for the new hospital. We moved. So I'm all about ambulatory care, right? I mean, that's how I got to be seen, because it was something nobody wanted to do. And then it became the lifeblood. And then it became as or more important than what else we're doing. So my whole bias was, inpatient care for the most ill and the most acutely in trauma. But everything else I'm going to get out as fast as I can. I mean, I'm an ambulatory care guy to start with. And so I think that's not a bad orientation today. And I think the reality is, as physicians, I helped, one of the jobs in consulting, I helped OrthoIndy add inpatient beds to their outpatient facility, where my wife just had knee surgery literally 6 months ago. And so I'm very much into and all for that. And the more we can have alternative sources and places, the hospital can no longer be the center of the universe as a place to go. It is still critically important as the center that can train, that can orient, that can provide the most severe and acute kind of care of people that need it today. And again, with people, baby boomers,
so
that's what's
elaborate on that, Bain. I was really hoping you would go there, because the hospital's still critically important. It's just the role has got to change. And administrators, the CEOs of hospitals and their executive teams and the physician leaders all have to embrace that change. Talk about where we're headed.
Well, and if you want to talk about what gets people to change, Jim, pay them different. I mean, to the degree we start paying for telephonic medicine, to the degree we start creating AI that allows you to 24 hours a day answer. I'm involved in a startup company on the board that's doing a lot of healthcare stuff, that I can have AI replicate Dr. X. And you could call him at 3 a.m. and he knows what Dr. X knows. He knows who you are. And he has he can answer a whole bunch of questions. And at some point in time, he'll say, now I need to call Dr. X. No, not, well, when you see it, it's unbelievable. And we're just at the we're just turning over the rock for it. I mean, it's just started. So it's absolutely essential. And I'm more optimistic about the future. Somebody else that you need to get on your podcast is Ben Lytle. He's written books about this, and the last 2 books he's written are very optimistic about the future, even in healthcare.
I think this trend to lower and lower acuity for care is a unique instance where quality and cost align. If you can do home PT, that's better than doing facility PT, which is better than doing outpatient, which is better than doing inpatient. It's a unique coalescence of quality and cost aligning. That's not always the case. So when you look down the road in 10 years or 15 years, what will be the role of a hospital relative to what it is today? Well, because today they're still largely the center of the universe in healthcare. They have the most money, the most capabilities. What will it be in 10 or 15 years?
If you're talking my hometown hospital, Davies County in Washington, Indiana, it's very different than St. Vincent's in Indianapolis, very different than IU Medical Center downtown. Those are 3 very, very different places and I think it'll be very different along those 3 lines. Hospitals will continue to be 10 years from now, the center of training I was on a board, a subcommittee board of the American Accreditation Council for Graduate Medical Education, ACGME. And I just got off a 3-year term. And they certify all the 600 and some residencies in the country. So training for physicians is still going to happen in hospitals. Ergo, they're still going to be important. The most severely ill patients are still going to go to hospitals, and therefore they're going to be important. And if done right, they will be able to create the umbrella for care that tries to make the outpatient care, the home care, the telephonic care, the AI care seamless, so that as a patient moves. My wife just had knee surgery, I told you, and we're Medicare patients. And the outpatient, the home Medicare, because she had fallen and had other problems, was paid for by Medicare up to the degree we needed it. And then she went to the center. So Medicare's doing some of that already. You said that, and that's true. I'm worried about Medicaid, candidly, because I don't know that Medicaid has the advocate. Medicare has plenty of advocates. The whole baby boomer population amongst others. Medicaid doesn't have the advocacy that it once had, and that's a worry that it looks like it's under the gun for some bigger cuts that they can ill afford at the moment.
So, Bain, what are some of the things you'd really want to impart on leaders of health systems, hospitals, medical groups, the folks that are trying to struggle with all this change so fast and are talking about the shift from volume to value? Now, for the umpteenth time, we're talking about that. What do you want them to know? What do you want them to hear? What do you want them to remember from this podcast?
So none of us who were in healthcare as a career for a lifetime and were perceived to be successful did it without mentors. None of us did. And I can list my mentors if we had time, one of which was Sister Teresa Peck, the best CEO I've ever met. And I've studied lots of them. So every person who's working in healthcare today needs a mentor or 2 or 3. 2, we don't study enough once we're gone. This job is a lifelong learning job. Peter Senge said that, 30 years ago, 40 years ago, probably now. But he, it is a lifelong learning job. That which I learned in my master's in health administration was probably 25% of what I used the last 10 years I was a CEO. I had to have the other, 75% someplace else. And 3, no matter how frustrating it gets to work with physicians, you've got to find a way to find people who can advise you, can counsel you, who can explain to you, and then who can advocate for you. One of the physicians I met in Los Angeles, when I stopped another doc who was doing some bad things, and the previous administration wouldn't. He's a Japanese physician, a famous heart surgeon in LA. I saw him right after I told the doctor he could no longer do what he was doing. And I said, I'm going to be dirt in the doctor's lounge for about the next month. And he said to me, and my Japanese accent isn't very good. He said, don't worry, I take care of that. He said, Dr. Such and Such, not a very good doctor. The previous administration wouldn't stand up to him. I'll take care of that. And again, that was the guy I met the first week I was there. So you even physicians who you think don't like you, don't know you, don't want to work with you, everybody wants to talk to who's in the seat, who's in the corner office, and take advantage of that and get to know as many as you can and use them as advisors.
Thank you, Bain. It's been wonderful.
Enjoyed talking to both of you.
Yeah, thanks so much, Bain.
Yeah.
Appreciate it.